Welcome to this explainer. When we think of psychiatric hospitals, our minds almost automatically jump to doctors, nurses, medications, the whole clinical shebang. But today, we're going to flip that script. We're looking at mental health recovery through a completely different, deeply human lens. We're drawing directly on the writings and lived experience of Andrew Turtle, who actually documented his own intense journey through a severe manic and psychotic episode, involuntary hospitalization, and the really long road back. Through his story, we are going to uncover an absolutely crucial paradigm shift happening right now in mental health care.
So, here's a massive question for us to start with. What actually heals a mind in crisis? And what's really fascinating here is that the answer isn't always sitting right there on a prescription pad. When someone is in the grips of a mental health crisis, their reality is completely fractured. They are often terrified, confused, or maybe entirely unaware that they're even unwell. And sure, medical stabilization is absolutely necessary just to keep them safe, but medication alone doesn't rebuild a person's life. So if clinical tools just stabilize the crisis, what actually heals the human being?
To really get it, we need to step inside the environment of crisis care. This quote from Andrew brilliantly captures the profound isolation and total loss of agency you feel during involuntary hospitalization. Imagine being in a place where literally every basic human decision, when you eat, when you sleep, who you can see, is suddenly made by someone else, often watching you from behind a pane of glass. It is an incredibly vulnerable place to be.
So, here is how we're going to navigate this paradigm shift today. We'll look at the isolation of involuntary care, the limits of clinical training, finding connection among peers, the lived experience advantage, and finally, bridging the care gap.
Okay, moving right into part one, isolation of involuntary care, life behind the glass. Let's talk about the immediate emotional impact here. Psychiatric wards are absolutely designed for safety, but that exact same design inadvertently creates this atmosphere of intense powerlessness and profound loneliness. You're basically just waiting for meals, waiting for meds, waiting for discharge, and the freedom we all take for granted completely vanishes the moment those ward doors lock, leaving you alone with some very distressing thoughts. Which brings us to part two, the limits of clinical training and treating the symptoms. This perfectly highlights a huge gap in traditional paternalistic care. Clinical interventions save lives, no doubt about it. The hospital gives you a safe environment, the staff monitors you, the meds kick in. That is treatment. But recovery? That is a whole different ballgame. Recovery is what happens after you survive the crisis. It's the much longer, much harder journey of actually rebuilding a human life. And if we look at it side by side, it really illustrates this fundamental difference. On the left, the clinical lens is all about risk management and symptom reduction. It's something done to a person. But on the right side, the human lens of recovery, that is all about rebuilding identity, processing trauma, and finding purpose again. You can be successfully treated, meaning you're no longer in immediate crisis, but still feel entirely unrecovered and disconnected from who you used to be. All right, let's explore part three, finding connection among peers, the unlikely lifeline. Here is the absolute paradox of the psychiatric ward. Amidst all that isolation and observation, patients unexpectedly find this deep community with one another. Andrew talks about meeting a fellow patient he nicknamed Generosity, who just shared his food, checked in on folks, and spent hours talking about philosophy. They found a shared vulnerability right there in the ward. It's honestly fascinating how a running joke about philosophy with a fellow patient did way more to foster daily healing than any formal clinical authority. They use this concept of dialectics, the idea that opposing views can both hold truth, to cope. This wasn't a clinical intervention at all. It was just two human beings connecting in the chaos and finding a lifeline. So, let's move to part four, the lived experience advantage. I've been there. When you break it down like this, you can clearly see the unique value that clinical training just cannot replicate. Clinicians are providing that absolute essential medical safety from the outside, often looking through that glass door. But a peer, they are right in the room with you. They understand the terror from the inside out. When you're terrified of being judged by a doctor, a peer bridges that gap purely through mutual understanding. So what exactly is a peer worker? Well, they aren't just a friendly face. They are professionals, bringing their own lived experience of mental distress and recovery directly into the services. They know exactly what it's like to face the stigma or rebuild an identity from scratch.
They are walking, talking proof to a frightened patient that there is actually a real, tangible future beyond their diagnosis.
Which leads us to our final section, Part 5, Bridging the Care Gap, Integrating the Human Element. Let's dive into this because it clearly outlines the irreplaceable benefits of this workforce. In a system that's so heavily reliant on containment, peer workers literally inject the human element back into it. They break down that whole us versus them culture, reducing fear and mistrust. They help navigate that incredibly tricky transition from just treating symptoms to actual human recovery, providing a level of empathy that you literally cannot learn from a textbook.
This right here is the ultimate message of the peer worker. Imagine sitting in a locked ward, totally stripped of your autonomy, and someone sits right next to you, no clipboard, no glass door, looks you in the eye and says those exact words, "I've been where you are." That creates hope in a way that purely clinical interventions just can't match.
I want to leave you with this really provocative thought as we wrap up this explainer. If recovery is fundamentally a human process, and not just a clinical one, how can our healthcare systems possibly afford not to include these voices? We absolutely have to recognize that those who have navigated the darkness are our most powerful tools for bringing others back into the light.